Recording in progress.
I kind of want to start off this live session by saying good job on last week's knowledge check. I think there's only one missed concept, kind of like fractions. And then you guys did phenomenal on your quiz. So we're going to keep that momentum going. Now, I chose this quote intentionally for this course. And the reason being is that my eyes are like so itchy, guys. Sorry. Pharmacology can feel very intimidating. Why? So you've already had micro, right? You've had theory. So you've got a lot of the basics. And then we bring in pharmacology, where now we're bringing in all these medications. And if you haven't been in healthcare before, you're hearing um, everything from metformin to lidocaine, epinephrine, marcaine. We're talking about safety considerations, calculations, and a lot of responsibility. Feeling a little uneasy does not mean you're not capable. Just remember that. It usually means you're taking patient safety serious. So I want you to know that's not a weakness. That's professionalism developing. And we're going to keep this momentum going. Okay. Everything you want in this course, confidence, clarity, competence, sits just behind that initial fear. We're not rushing through it. We're building understanding step by step. Give me a second, guys. My eyes are watering. My allergies are like everywhere. All right. So let's talk about perspective. We are not prescribing medications. I have been asked this a couple times in previous modules. When they get to module 3 and we're getting all these medications, and they'll ask me, "Are we prescribing them? Prescribing them?" No, but we absolutely play a role in medication safety. From the system to the syringe, there are multiple checkpoints designed to really protect our patients. Our role sits within kind of that system as a whole. But here's the key: even though we're not the ones like administering the medications independently, our awareness does matter. Now, medication errors rarely come from just one mistake. They usually happen when like small safety checks are missed along the way. Our job is really kind of just staying observant, staying informed, and engaged. If something feels unclear today, I want you to know that it's okay, okay? Because we're trying to build on that understanding. We're not rushing to mastery. With that framework in mind, let's move into the first concept. So I like this question because most of what protects patients we never actually see. Before medication ever reaches the sterile field, it's passed through layers of safeguards. Each of these rings that you guys see represents a layer of protection, policies, regulations, standards, and laws. They exist to catch errors before they reach the patient. And with that, at the center of it all is our patient. Again, when something feels like strict or repetitive, it's usually because it's a safeguard and it exists for a reason. Now, as you guys are looking at this, which layer do you think we as techs interact with the most in the operating room? What do you guys think? Is it the international laws, state laws, federal regulations, internal laws? Um, okay, a lot of federal. We're kind of like both because Joint Commissions, FDA, DEA, OSHA, yeah, that's kind of like our lane, so to speak. So you guys are right in the right space. Now, medication safety isn't one action, one person, or one checkpoint. It is a system. Each of these organizations play a different role. And I like how you guys were kind of like right in the lane because these are where these different elements kind of live. Okay. FDA focuses on approval, labeling, and safety standards. The DEA controls how certain medications are regulated and tracked. And Joint Commission ensures hospitals are following safety or safe practices consistently. Now, again, we're going to look at the process, okay? Keep the system in mind, okay? We're going to look at, as my thing was trying to go faster, the pillars of the system. And I say that because medication safety doesn't start in the operating room, it starts long before that. Once on one side, you have development, how drugs are tested before they even reach the patient. Those phases exist to answer one main question: is this medication safe and effective? On the other side, you have control, how medications are regulated once they've been approved. That's where scheduling actually comes in. I don't want you to think, oh my goodness, I need to memorize every detail. What matters is understanding why these systems even exist. They reduce risk, prevent misuse, and protect both patient and the health care professional, which is us. Now, how does knowing these systems exist change how you view medication policies in the hospital? I want you to kind of sit with that and think about that. Okay. And the reason I say that is because together, these systems are designed to kind of slow things down when it matters. This is how safety is built, not through shortcuts, but through structure. Biggest thing that you want to know, you may see, they may ask, how many stages are there for FDA drug development, or phases, I should say. Make sure you know them because I have seen concepts as well as scheduled substances. You see one, two, three, through five. Okay, so just make sure 1 through 4, 1 through 5. Okay, DEA 5, FDA 4. Okay, so we're talking about these strong systems, regulations, the policies, the safeguards, but even the strongest systems depend on human behavior. Most medication errors do not happen because someone didn't care. They happen because assumptions, maybe there were distractions, um, there was time, pressure, or it could be straight up just miscommunication. This is why the system becomes, or this is how I should say, the system becomes fragile. We as STs, we're going to be a part of that human side of the system. Our awareness, especially in routine moments, matters more than you may even realize. This isn't about being afraid of mistakes. It's about kind of learning to recognize where errors tend to kind of happen and then slowing down just enough to interrupt them. So, a question for you guys, you can type it in the chat. Why do you think errors are more likely during routine or familiar tasks? They're not in the right order. So I've been having errors signing in. Oh, okay. Um, assuming is a big one. Anything else? What's another reason why errors would occur during routine tasks? Different opinions, all patients react the same way. Multitasking. You may get uncomfortable. Rushing. Yes, keep them coming. These are good. Not verifying. You guys are right on the right wavelength. The other thing to think about, as you guys are still saying, sterile processing the right way, thinking it's not important. I love that one. Now, patient safety is not about rules, it's about how consistently we apply them, especially when we feel things are routine or not important. So, here, now this is one of the most common and dangerous assumptions in medication safety. Drug names aren't just labels, they actually do carry information. So, brand names, generic names, lookalikes, soundalikes all exist for a reason. Each one can affect how medications are ordered, prepared, labeled, and even verified. Some differences in like spelling or even just pronunciation can lead to very real consequences. Now, as STs, again, we're not the ones necessarily selecting the medication. We're looking at our surgeon's preference card that we're going to talk about in 300 later on in the module. But we're seeing them. We're recognizing names. That's going to help us notice when something doesn't match the expectation. Again, this isn't about like, oh, we're going to catch all the mistakes. It's about kind of just slowing down just enough to prevent them. Now, have you ever noticed how similar drug names look, even at a glance? Kind of think about it. Yeah. So, like, you're looking, and you're like, wait. And then you have to kind of do like a double take, right? This is something that we still have to kind of trust but verify, even when our surgeons or our circulators are grabbing stuff. Yeah, could be a knockoff. Sometimes it's just like the Walgreens or the Rite Aid versus the brand name. Okay. Now, when people hear right dose, they usually think, oh, they're talking about a number. But dose is not just a number, it's a decision made up of multiple parts. The right dose only exists when three things align. First, the right medication. Second, the right strength or concentration. And third, the right route. If any one of these are off, the dose is wrong. When in doubt, throw it out, even if the math is correct. We are in a position where we are able to notice when something just doesn't match the expected or the expected medication, the expected strength, or the route. Most medication errors, they're not going to come from bad intentions. They come from, again, that word, assumptions. Now, this is going to help us to kind of slow down and be able to check those assumptions. But let's break it down just a little bit more. Again, these cases are not about blaming anyone. I want to very much kind of emphasize that. In the first case, the medication is correct, but the strength is different. That difference alone is enough to change the patient's outcome. Yep. You guys are doing great. Misuse, miscalculations as well, how much the patient can also take. These are all factors that come into account. Now, in the second, I want you guys to look again. The medication and the strength may be correct, but the route is not. And route matters just as much. 1 to 1,000 is very strong versus 1 to 100,000. not only that, it can hit faster than the other. Not only that, depending on the type of medication, it can cause anaphylaxis. It can cause different, depending on what the medication is, right? Yeah, it can cause different reactions to the patient and cause harm. Something that is topical um, is not going to be something you want to inject into the system, because something in the system is going to go fast. And here we're talking about something that's 100 times, this one's 100 times more potent than this one. Okay. Both of these situations happen when we focus on one part of dose and assume the rest. We're like, oh, that's epi, I'm good. But if you notice, these and when you have the bottles in your hand, sometimes I gotta move my glasses just to make sure, because the numbers can sometimes be small, right? And so you want to make sure that as the patient's advocate, you are doing the best that you can for that patient. Also, you may have four clear liquids, and I know I've said it before, four clear liquids on your field. 2 doses of heparin, maybe a Marcaine with epi, um, a normal saline flush, like especially if you're doing a central line placement, you're gonna have a couple clear liquids that you want to make sure is written. You may have both a topical and an injectable, right? You got to make sure you're handing it up at the right time. Yes, so you're meaning like IV is gonna get into, yes, IV is going to be able to get into your system a lot faster in most cases because it's going straight into your system. Oral is fast as well, but it's going to depend on a lot of different factors. I want you to think about what that medication is. Yeah, so you're thinking correctly. But for us in the operating room, we're not giving anything oral, so it's always going to be either IV or local injection. So good question, or good point actually. Now, let's bring it all together. Okay. All of the systems that we talked about, regulation, drug development, verification, and eventually coverage at one point. This is why we practice. This is why you'll be practicing in the lab. Okay. Next module. Being the final safeguard doesn't mean that we're working alone, right? It's not all up to us. Okay. It means that our actions matter within the team. Medication safety doesn't happen passively. It happens through deliberate, consistent behavior. We're labeling medications immediately. We're stating medication information clear for verification. And we're maintaining accurate awareness of what's been given. These aren't extra steps, they are protective ones. Now, this is part of developing that professional mindset that you guys are getting. You don't have to know it now, right? But this is why you guys are doing awesome staying engaged. You're going to be observant in the operating room. You're going to be willing to speak up for your patient. So let's talk about something you may see in this upcoming exercise. Okay. Now, this slide represents one of the most important safety tools we use in the operating room. Okay. It's a script for a reason. Now, we're not in the operating room like robots saying label, blah, 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 right? But we kind of just go through the flow, kind of like our timeout. It's a script that we go through regularly for each and every patient. And so we kind of do the same thing for each and every medication that is given to us on the field. It is a required safety procedure, so it's not just a conversation. And the order and repetition are intentional. Every step is designed to make sure everyone is seeing, hearing, and confirming that same information. I want you to notice how the process uses multiple senses. You're reading, you're speaking, you're showing. See if I have my eye drops, because this is a big one. So let's see. Monique's in front of me. Okay, so I am Monique's circulator. I am reading refresh liquid gel, lubricant eye gel. Okay, I'm reading it and then I'm going to show it to her. I'm going to let her see what this is. And then as I'm showing her, she's repeating it back to me. This is what we do in the operating room. Okay, Then the next thing, we are saying everything that it is. Okay, we're making sure she sees that expiration date. February 2026. I'm showing her February 2026. She's repeating it. She's saying it out loud. Okay. Then she's going to accept the medication. I'm going to show you how we do that in ST300. The redundancy is what catches the errors before it even gets to that patient. And then you're labeling immediately. That closes the loop. This right here protects all of us. It creates that shared moment where we're kind of slowing down together. It's usually just me and my circulator, but a lot of times your anesthesiologist is hearing too. Because let's say there was a allergy that they just found out and they're getting ready to write it up. And we have epinephrine and the anesthesia's like, we just found out this patient's allergic to epi. We're going to throw it out. Patient's not in the room yet. We're getting it out of the room. Okay. Now, which step in this process do you think is the most critical and why? Which one do you think is the most critical? And there are no wrong answers, you guys. This is just kind of us going through 5 and 6. Okay. Scrub accepts the medication. Big, I like you guys are in the same room between 5 and 6, right? You want to make sure that you're labeling exactly what you see. You are trusting but verifying. I trust my circulators, but I'm verifying that what they're giving me is indeed what's in that bottle. Yeah. So again, there are no wrong answers here. Just kind of want to see where you're going at, okay? Now keep in mind you may see a concept like this on your exercise. So, kind of be comfortable going through the flow. Here's another one you may see. This right here represents one of the clearest rules in medication safety. If it's not labeled, it's not safe. When in doubt, throw it out. Every medication must be labeled immediately. There are no exceptions. Now, this rule exists because unlabeled medications are one of the fastest ways errors do unfortunately reach our patients. Even if you think you know what it is, even if it's just for a moment. Okay? Yes, and date it. So here we would have, you see it kind of right here, right? You have your bubuvacaine, HCl is 0.5%. It's 50 mLs, 50 cc's. Expiration 10/26/24. We would throw this out because it's 26/26, right? But for the slide purposes, you kind of get what I mean. A complete label answers 4 questions. What is it? How strong is it? How much is there? Who prepared it and when? In most cases, you may, if you have room, you'll put your initials. Um, if any one of those is missing, any of these 4 are missing, the label is incomplete. The cool thing is we have some labels that are pre-printed. So a lot of times you just grab them. They'll have bubuvacaine, and then it'll even have 0.5%, 50 cc's. A lot of times you're just writing in the expiration date and kind of putting your initials. Okay. Sometimes we've written them. What matters isn't how the label looks, but is this information correct? Is it complete and immediate? Yes. So bubuvacaine is the name of the drug. So the question is, should include the name of, or the comment, it should include the name of the drug, the dosage, must have the prescriber's signature. So, or initials, just depending on where you are. Okay. But we'll always go by what the book says. And then again, book, real world. Okay. So a lot of times in the real world, you may not see the initials. They should still put their initials, but all the other components have to be there. Okay. Have to be there. Now, this is one of those practices that defines us as professionals. Professionals. Okay. Again, it's not going to be something that you're going to have to memorize because it's going to be muscle memory. I know it sounds crazy, but it'll be muscle memory. Like every time you get ready to grab a drug, go through it, you're going to be Hold on, Samantha. What was that again? Show me again and have her show you. It's okay. Because again, at the end of the day, it's about the patient safety. Does that make sense before we move on? Thumbs up? Okay. I stress that because this is big. I've had a student pulled from their clinical rotation because they almost passed up the wrong dose of heparin. So I get really like, let me make sure I tone this in because it's not even about their grade at that point. Like, you're in clinicals with a real patient, you know? Now, here's another slide that answers a question often asked. Why are we so specific about these particular things? Okay. And it's because small actions can have huge effects on patients' physiology and their recovery. A lot of times that's why we are verifying. Yes, their lives are on your hands. We're verifying. Someone can die. Like, you guys are on point. Yes, someone can die. Confirming weight-based drug dosing protects those vulnerable patients. You guys can type yes or no. Do we have to check? Let's say you're doing, let me rephrase that. You're doing an appendectomy. You've got 4 appendectomies today. Okay. You have a preemie, 2 point. You wouldn't do an appy on a preemie. Scratch that. You have a 10-year-old. Okay. Regular BMI, we'll say like 18. You have a 36-year-old, 240, 5'3". You have an elderly patient who's 90 years old, maybe 90 pounds, and you have a 22-year-old football player. Do you think, yes or no, that each one of these each one of these patients will receive the same amount? You guys already know of medications. No, right? They're not. There's no way. Because, especially the child, right? Because with weight, comorbidities, there may be other factors that we play into it, right? So you can't give the patients the same amount of medication, right? So what do you mean? So what part would you like me did you miss? The like the scenario, like the medication part or the case? So I'll try to briefly go back. So we're doing appendectomies. You have 4 patients that have potential ruptured appendix. So we're trying to get them back into the operating room. Now, it's the same name of medication, but would we give those patients the same amount? And everyone was saying no, because one, it's going to be the weight, right? You have to go by the age, weight. We have a whole calculation that we go through, especially when we do little ones like preemies. You're giving them 0.05 cc's, like, and you're counting everything because you cannot give them more than a certain amount. And you're doing the same case. So this is how or why verifying drug compatibility is really important. Okay. A lot of times we use room temperature irrigation that prevents tissue injury. You may see that concept somewhere. And when we're administering antibiotics, we're doing it at the right time. That helps prevent surgical site infections. Now, let's look full circle. We've talked about systems, we've talked about safeguards, protocols, communication. All of that funnels down to one place: care. When we looked at being the point of care, that doesn't mean that, again, we're going to be responsible for everything. They're not going to be like, Stephanie, you didn't do this, right? It just means that our attention, our focus, and our consistency does matter. Medication safety is not going to be about perfection, it's about awareness. Every time you slow down to verify, you label or communicate clearly, You are protecting the patient. Now, that's what professional practice actually looks like. Which habit we discussed today do you think will matter most once you're that first scrub at your sterile fields? Consistency, labeling, verifying out loud, attention to detail, verifying. Yes, verifying. That's going to be big. And if you just take one thing from today, attention to detail, verification, it all comes back to patient safety. And that's because our roles matter every case, every time. You'll also notice that when we do have like these one chapter cases, we're able to break down things a little bit more and we move a little bit faster. So just kind of keep that in mind. Now, I want to share the Kahoot link. Now, this is a little bit different than what you're used to. Okay. You may find this helpful as you get closer to midterms. And I know we're only at week 2, but y'all know it's going to come so fast. So even starting next week, I'm going to be focused on that week's chapters, but also honing it in to what to expect for midterms. Okay. Now, I want you guys to use this anytime as it supports your learning. But what you'll notice when you click on it this time, it's slightly different. So I kind of want to show you how it goes. Here, it's for individuals. So you can do it anytime. You kind of like just spin it. Y'all know how to do that. That's, what we normally do. Okay. And then you have the opportunity to kind of do it. You don't have to wait for anybody else to kind of join in. Um, Okay, so you guys got that. Okay. So oh my goodness. I did not know it was gonna be that loud, y'all. I apologize. Sorry. Um, so I kind of had to change the link because before, and someone had just told me in the my last class, they were like, "Hey, I tried to click on it," and I was like, "Oh my goodness!" So I had to change it so that you can click on it anytime now. The only caveat is they gave me a time frame, and so come February 9th, because I want you guys to have these as you guys go into midterms. I just have to extend the date. So somebody just kind of, I'll try to remind myself, but um now you don't have to have that other players anymore. So it was just me. I had to do another little. So now that's done, and now you're able to kind of go in at any time, anywhere. Okay. Um, yeah, no, yeah, you're welcome. Luckily, someone in my last class kind of told me that, and I was like, oh wait, you can't really play it this whole time. I just been like Kahoot link, Kahoot link. Sorry, guys. So now you have it. With that, all right. So with these shorter chapters, we do have more time. So I do want to open it up for any questions that you have before I kind of wrap it all up. If you don't have any questions now, that's okay. You guys are really doing well. And I think I mentioned that usually pharmacology is usually the strongest um, course for some reason. Um, Mainly probably because we have to pay so much attention. And so this really ties into 300. But the floor is open. If you guys do have any questions, you can type them in, or you can say no questions now, whatever you feel comfortable with. Okay, I have one for no questions. Is that kind of like for everybody? Okay. So the key is if questions do rise up, you guys know that um you guys have your tutoring office hours is right after this. So that's always an option as well. No pressure, but just know that it is available. Okay. All right, perfect. If you do Send me a message. Okay. Now, as per usual, whoever sends me the message, I will respond first back to them, and then I will put on an announcement for everyone else because you never know, someone else may have that same question. Now, let's talk about some takeaways from today. Medication safety is a system. Remember that it's not a single action. Um, Quick question. So, do we have class next week? If you guys have classes on Monday, check with your professors because Monday is a holiday, so they may have removed them. We have class on Tuesdays and Wednesday. Tuesday and Wednesday. But for anyone that has, if you guys do have a Monday class, just check with that professor. Awesome. Good question. Okay, so Tuesday to Thursday, so then you're good. Okay, perfect. Now, the takeaways. I want you guys to remember that medication safety is built on layers of protection. No one perfect decision. Human, we are the ones that activate them. Okay? Errors rarely occur, thank goodness, in isolation, but they occur when the systems and people, like, they're not aligned. We are the final safeguard. That doesn't mean that it all falls on us. It just means that once a medication reaches our hands, we are the point of care. Our role is active, it's deliberate, it's essential, it is never passive. Systems are strong, but fragility in systems comes with, what's that term? To err is human, right? Assumptions, shortcuts, misinterpretations. These are things that unfortunately can happen. Right dose is not just a number. You guys saw that. It depends on the drug, the strength, the concentration, the routes. There's other things that even contribute to that, the patient's weight, the age, right? Comorbidities. An error in any one results in a wrong dose. Most dose errors are thinking errors, not math errors. And then safety depends on a standardized exchange every time. You guys remember that circulator is going to read it aloud. Okay, they're showing the label. We are repeating that information. We're accepting the medication and we're labeling immediately. Skipping a step doesn't save time, it transfers risk. I love that. It's very important to always pay attention to all medications. We saw look-alike, sound-alikes, right? Where you even had the exact same drug, different concentrations. One's topical, one's local. And if it's not labeled, it's not safe. No expectation, no exceptions, I meant. When in doubt, throw it out. Okay? And no exceptions either. Every label has to have medication name, strength, concentration, volume, date, and initials. Labeling is a real safety action, not document for later. Okay? And we verify compatibility. That's going to prevent dangerous interactions. Does this person have a shellfish allergy? Are they allergic to peanuts? Or, granted, we're not giving them peanuts in the operating room, but are they allergic to penicillin or anything else? Proper antibiotic timing. That reduces surgical site infections. We use room temperature irrigation, prevents hypothermia. And weight based dosing products are vulnerable. We look at those for our vulnerable patients, right? And that's because you may never see the outcomes. A lot of times we don't see it, but our actions do shape them unless you have a repeat patient and they're repeating because of something that may have happened on our watch. Also, remember, I think someone said it, attention to detail, clear communication, and teamwork. Now, for those of you that are watching this archive, how can you, as a CST, prevent a medication error when multiple drugs with similar names or concentrations are present on the sterile field? I mentioned you may have up to 4 or 5 clear liquid syringes. I want you to consider labeling practices, visual verification, communication with your circulator. If something about a medication label, concentration, or route does not align with what you expect, what action should you take as the scrub? And last question, why is the CST considered the final safeguard in medication safety, even though we are not administering that medication? I want you to reflect on the sterile field control, verification responsibilities, and shared accountability. Our quote of the week, everything you want is on the other side of fear by Jack Canfield. So now we're in week 2, y'all. We've got 9 weeks left, right? 8, 9, 10, 11. You guys know, right? And I am really impressed at how you're beginning to kind of do these things. I was looking at your, like I said, your quiz and your knowledge check, and I was like smiling. I was like, okay, we're going to keep that momentum going. Again, if you do have any questions, I am here. If there are no further questions, we'll get out a little bit early if you guys are okay with that. I do wish you all a wonderful evening, and I look forward to seeing everyone who can join tomorrow's live session. With that, good night, everyone.